So our next topic is NHS Cervical Screening Program, Screening and Management of Immunosuppressed Individuals. So what is the definition of immunosuppression? Immunosuppression includes individuals who are on immune suppressing medications such as post-transplant medications, or the patient is receiving medication for autoimmune disorder or neurological disorder. Okay, or the patient is a transplant recipient, any organ transplant recipient, or have renal failure which requires dialysis, or have an HIV infection or other condition leading to the immune suppression. Okay, immunosuppression increases the susceptibility to HR-HPV infection, but does not accelerate or progression from HPV to CIN or cervical cancer. Hence, strict adherence to the screening schedule is essential. This particular guideline or this particular sentence, you should remember that what is the effect of this immunosuppression? It will favor the HPV infection, but the oncogenicity from HPV infection to the CIN, it does not get accelerated because of the immunosuppression, but it will increase the susceptibility to the HR-HPV infection. Is this clear to you?
Yes, sir.
Okay. So what is the management of immunosuppressed individual? Okay. So if the patient is on renal failure and dialysis, perform cervical screening at or soon after the diagnosis, if not up to the date. Sometimes they can ask you about the renal failure patients. What is the guideline? Okay. If the at the time of diagnosis or soon after the diagnosis, you have to do the cervical screening. Okay, that is irrespective of the previous screening. Okay, the individuals awaiting organ transplantation must have screening within 1 year before the surgery. So if the patient is awaiting for organ transplantation and due for organ transplantation, there has to be screening which is performed within 1 year of the surgery. If the results are abnormal, the patient will be referred to colposcopy as per the national pathway and manage any coexisting CIN as per the standard guidelines. Okay. Now coming to the post-transplant patient, what we have seen previously was a renal failure patient. Now here we are dealing with a post-transplant patient on maintenance immunosuppression. These patients will be receiving immunosuppressive agents. Okay. Now screen these patients according to national guidelines, same as general population. Abnormal screening results will be managed as per the standard pathway like a colposcopy and as per the colposcopic management, and educate transplant recipients and carers about the importance of regular screening. So these patients should undergo regular screening, because we have just seen that immunosuppressants will increase the risk of acquiring HPV, but not its progression. Okay, so that is why the regular screening is very, very important for these patients. Now, individuals with multifocal disease, management should occur in specialist centers with expertise. Balance between the risk of CIN and trauma of repeated assessment and treatment is there. Then conduct comprehensive assessment every 6 months, including, suppose if it is a multifocal disease, in that patients, what is indicated, a comprehensive assessment every 6 months you have to do. That will include the symptom inquiry, cervical cytology, colposcopy and vulvoscopy, and if indicated, you may have to do biopsy. But this is only for multifocal disease. Okay, consider high risk resolution anoscopy where resource permit, and anal cytology only in specialist settings is required. Okay. Now, other immunosuppressant individuals, like this will include on various patients on various agents such as cytotoxic chemotherapy, non-genital cancers, or anti-estrogen therapy like tamoxifen, then alemtuzumab, mab, and cytotoxic or biological agents for autoimmune disorders. There is no need for increased surveillance. They will undergo routine screening guidelines. So if the patient is on other cytotoxic chemotherapy or tamoxifen or cytotoxic or biological agents, okay, they will undergo routine screening guidelines. There is no additional screening. Additional screening we have seen for dialysis patients or renal failure patients at the time of diagnosis or immediately after the diagnosis. Okay, if the patient is undergoing transplant, then you need to have a preoperatively within 1 year. Okay, post transplant regular screening. Okay, and what is the importance of screening, that needs to be explained. Even for other immunosuppressed individuals, there is no need for increased surveillance, but the routine screening is to be followed. If biologicals warrant additional monitoring, local protocols may define frequency. Okay. Now the next topic is important, DES, that is diethyl stirbesterol exposure. This has been asked, I think, 2 years back. One of the EMQ was there. it was a different scenario, but the question was about the DES and further effect on the cervical cancer. Okay, now what does the literature says? DES daughters, okay, exposed in utero. So those daughters who are exposed to the DES, they are at a risk for development of the clear cell carcinoma of the cervix or the vagina. Okay, so they are at a risk of clear cell carcinoma of the cervix and vagina. Routine call recall screening is appropriate. So there is a risk, but the screening is routine call recall screening is appropriate. Those with DES related changes will undergo annual colposcopy and cytology. Suppose if there are changes, then they will undergo annual colposcopy and cytology even if HRHPV is negative. Okay, so this is only for the daughters, but the granddaughters of DES exposed women, they are not at increased risk of carcinoma of cervix. That was a question which was asked about the granddaughters of DES exposed women. They were not at increase. So there is no change for the granddaughters. Okay, even for the daughters, what does the guideline say? Routine call recall screening is appropriate. However, if there are DES related changes, then the annual colposcopy and cytology will be performed, irrespective of the HRHPV negative. Okay, even if the HRHPV is negative. Now, what about the HIV positive individuals? Screening and colposcopy should be done by or with HIV specialist team. Perform annual cervical screening with initial colposcopy if the resources allow. Okay, so here it is an annual cervical screening with initial colposcopy. Then follow standard management for abnormal cytology. Age range same as for HIV negative individuals. High CIN, that is CIN2 or CIN3, treat as per the guidelines. CIN1 or less, conservative management. Okay, monitor for progression. Okay, this is same as other patients. Okay, collaboration with HIV team to optimize immune status, that is improving CD4 count, and screening may cease at age 65 if other cessation criteria are met. So for HIV positive individuals, the same timing for the cessation is there. Okay, so only thing is that annual cervical screening with initial colposcopy. Otherwise, most of the things are same. Okay. So that finishes the topic about the immunosuppression and the cervical cancer screening. Thank you.